The goals of treating myelofibrosis need to be very individualized. As a life-threatening illness, the first question that needs to be answered, and consistent with our current NCCN guidelines, of which I had a role in establishing, is whether or not patients should be pursuing a stem cell transplant. Now, for the majority, that answer is no, either on the basis of their age, the risk associated with their disease, the lack of an appropriate donor, or patient choice. But it is a crucial question because I view that there really are two parallel paths, a path pursuing stem cell transplant or a path of utilizing medical therapy to optimize the patient with benefit to the greatest degree that we can.
There are still significant controversies on how to manage and how to treat myelofibrosis. The first question is, should we treat myelofibrosis or should we observe myelofibrosis without any specific treatment? What should be the guideline to treat? And what is available therapy for myelofibrosis? There is only one drug that has been approved by the FDA for the treatment of myelofibrosis. This is ruxolitinib, a JAK1/2 inhibitor that has been in use for several years. This drug has been approved for the relatively more advanced stages of myelofibrosis, ranging from prognostic groups intermediate 1 all the way to high risk. Low-risk patients with myelofibrosis are not approved for the usage of ruxolitinib, at least not formally. Now, the question is, should low-risk patients be treated with a JAK2 inhibitor, or should we observe this patient? And that's a subject of controversy. The key question will be, do JAK2 inhibitors prolong survival of myelofibrosis patients? That being the case, there will be clearly indication to go to the very early stage and try to prevent its progression and treat them as well. But this has not been yet subjected to a systematic study. Thus, we have to wait until this question will be studied in more expansive way.
It depends. I mean, I risk stratify patients that I see, typically with the dynamic international prognostic scoring system, in order to decide whether patients are risk adverse enough to warrant therapies such as hematopoietic stem cell transplantation, or whether their disease is low risk enough to warrant even watch and wait in some cases. So it really depends on a combination of the risk score, also the symptom burden, and a discussion with the patient about what their goals are. Typically, when we're trying to address symptoms, probably the most effective drug that we have to address symptom burden, whether it's constitutional symptoms, fevers, night sweats, weight loss, or systemic symptoms like bone pain, abdominal discomfort, itching, headaches, fatigue, JAK inhibition as a class of agents is the most effective, and ruxolitinib is the only JAK1/2 inhibitor that's approved. So typically, that is the first line of therapy, particularly when trying to address symptoms. And for the most part, most patients that are treated with ruxolitinib in particular have some degree of improvement in their symptom burden. It doesn't necessarily mean that every patient will have every single symptom disappear in every case. Sometimes some symptoms are improved and others remain somewhat troublesome. In some cases, all symptoms are improved to some degree but still can persist. But with ruxolitinib, it is probably the most effective drug, definitely the only approved drug that we have that really addresses symptom burden.
In my experience, which is fairly extensive, I have seen a vast spectrum of patients with myelofibrosis. They can have very few symptoms or can have extensive symptoms. And the patients that clearly require treatment are the patients who are symptomatic. Patients who lose weight and who lose muscle mass, who are severely fatigued, have anemia, have very large spleens, have pains in the bones and sometimes pain in the spleen. Those patients benefit from therapy. In several situations, the response to a JAK2 inhibitor, particularly when it comes to symptom control, can be absolutely dramatic, and patient can feel better within days, gain considerable amount of weight, and his quality of life can improve in an absolutely dramatic way. The question is, should we treat patients who are asymptomatic with this form of therapy, with a JAK2 inhibitor? And the question, as I said earlier, is still debated. If the JAK2 inhibitors offer therapy that goes beyond symptomatic help and beyond only shrinking of the spleen, but actually prolonged survival, then it's probably an indication to treat patients who are asymptomatic. But that is a question, not an answer. This issue has to be addressed in studies and see if early disease, we can prolong survival in this situation, because obviously in this early disease we do not manage symptoms because the patient don't have symptoms.